Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What's new with thyroid disease? Find out more right now. My guest this evening is Dr. Paul Sack, a noted endocrinologist with the MedStar Health System in Baltimore. Paul, welcome back to Housecall.
Thank you. It's great to be here.
So briefly tell our viewers about your background.
Sure. I'm an endocrinologist, which is a person who deals with hormones, mostly diabetes and thyroid. I did my training at the University of Maryland and have been at MedStar since 2005. I serve as the chief of endocrinology at Union Memorial Hospital and the regional director for endocrinology at the 4 MedStar hospitals.
Very nice. So let's, for starters, educate our viewers. Where exactly is the thyroid and what is its function?
Sure. So the thyroid is at the base of our neck, and I'm going to pull out a little diagram here. So most people think it's kind of up higher, but it actually sits pretty low. And I'm just going to put this up to my neck here so you can see it. The thyroid itself, I'll take it off my trachea here. Thyroid itself is butterfly shaped. And so sometimes you'll see it kind of the butterfly be kind of the representation, but there's 2 lobes and a connection in the middle, right lobe, left lobe. And typically the thyroid is about 4 centimeters to 5 centimeters tall and about 2 by 2 depth and width. So it's a not very large normally gland, but it's there to control our metabolism. And there's a lot to that. But the basic idea is if you don't have enough thyroid hormone, everything slows down. And if you have too much, everything revs up.
So if you're concerned about an over or underactive thyroid, what sort of blood tests can you obtain?
Sure. So sometimes these tests are done just for routine screening. Someone doesn't have any symptoms. The doctor's like, we're just going to see what your thyroid levels are. Sometimes it's done because people have symptoms. But the main test is called a TSH, which stands for Thyroid Stimulating Hormone. And this is not a marker of what the thyroid is doing. This is a marker of what the Pituitary Gland, that's the main hormone control center in the brain up here, is thinking about what your thyroid's doing. What the thyroid makes is called thyroxine, or we narrow it down to T4. And there's also a T3 hormone that we can measure. So the thyroid is making that hormone. The brain senses it, and then it tells the thyroid, all right, you're doing a good job. Make the same amount. Nope, that's too much. Make less. Nope, that's not enough. Make more. So this is the main confusion for patients, which is, wait, you're telling me my number is high, which means I'm underactive. My number is low, it means I'm overactive. Yes, the TSH is the response to what your thyroid is making, or potentially what you are taking if you are taking medicine for your thyroid.
Let's go on to discuss overactive thyroid. First of all, how does that present clinically?
Yeah, I mean, it can be anywhere from almost no symptoms to in the ICU, sick. So as I mentioned, the thyroid kind of controls our metabolism. And so when the thyroid is overactive, everything revs up. So typical symptoms would be some tremors, heart racing that you might feel, or just on your vital signs, the pulse is up, more anxiety, weight loss that's unexpected. You might have kind of increased bowel movements. Everything might get more oilier. In women, sometimes the menstrual cycles are less frequent and lighter. And there's some other things too, but those are the main ones. So when somebody has those symptoms, it's a natural thing for the physician to say, okay, let's check your thyroid. And if you are hyperthyroid, overactive with your thyroid, just to reiterate, the TSH will be low and the T4 levels will be high. And there's several reasons why the thyroid can be overactive, and I don't want to talk about each one, but I think the big 3 are important to discuss. So the first one, which is potentially the most common, is something called Graves' disease. And Graves' disease sounds scary. It sounds like you're going to go to the grave. but it was actually named after an Irish physician who described it, named Dr. Robert Graves. So I'd like to make sure my patients understand this is most of the time not a grave condition, but that's a situation where the immune system gets tricked. And we call this an autoimmune disease, where the immune system, which is supposed to be fighting viruses and bacteria, suddenly flips and starts attacking self. And in this situation, it makes something that we name thyroid stimulating immunoglobulin, which is a big fancy word for a protein made by the immune system. And that looks exactly like that TSH. So the poor thyroid has no idea that it's not supposed to be doing this. It's just getting the on signal. So it's like, all right, we're going. And that just makes a lot of thyroid. That causes the thyroid generally to grow as it's being told to make more and more thyroid hormone. And these levels can get really, really high, the amount of thyroid hormone that's coming out. The next reason people can get overactive is just one area or maybe multiple areas change in some way. So they're just on. They don't need an on-off signal. It's like a light switch where it doesn't matter what you do with the switch, the light's just on. And going back to my little diagram here, this is a thyroid that has a lot of lumps and bumps on it. And you can get nodules that are overactive. We call it a toxic multinodular thyroid. Those aren't usually as severe in the amount of thyroid hormone that it can make, but it still can be symptomatic. And the final one to wrap this part up is called thyroiditis. So itis means inflammation. So inflammation of the thyroid, which typically we think it would be viral. Sometimes it's autoimmune. Sometimes it's traumatic, like a seatbelt across the neck. But that's basically where the thyroid suddenly releases all of the hormone that it's been making ahead of time and storing up for later use, comes out like that. The difference is in that situation, that's a short-term course of hyperthyroidism. And then eventually goes away because you've used up all of that thyroid hormone that was pre-made, and then you're left with the thyroid that may go back to normal, or actually then at that point goes underactive.
One of the known associated symptoms is, of course, thyroid eye disease.
Yep.
When the thyroid is overactive like this. Tell our viewers, how is that connected, the thyroid and the eye disease? How do you diagnose it, and what are the treatment options?
Yeah, so it's interesting. A lot of my patients come in asking about this because there's a new medication on the market and they are advertising everywhere. So it's a big topic of discussion. But thyroid eye disease, and the fancy name is exophthalmos, is basically where those same kind of immune proteins attack the cells behind the eyes, and it actually causes inflammation behind the eye in the muscles, and it pushes the eye forward. The eye is actually not getting bigger. It just looks bigger because it's less inside the eye socket and more kind of coming out. And you'll see that in most people's eyes, you do not see white above the iris, but in people with Graves' disease, they'll get the full circle of white. So there are ways to measure kind of the extent of that, and eye doctors can do that. But most people, you just see it and you're like, yep, that's from Graves' disease. Interestingly, you can get the eye disease without the thyroid disease. So it's not always hand in hand. And it's about 50% of patients with Graves' disease will get the eye disease. It can be severe, where it can actually interfere with the vision and with the muscles that are used for tracking things. So you can get double vision, blurred vision, gritty feeling on the eyes. As I said, there's a new medicine out that can help with that, and steroids have been used in the past, and surgery.
And with surgery, what exactly do they do?
They basically decompress the muscles behind the eye, so they can kind of fit back in there better. We try to stay away from that. And again, with this new monoclonal antibody medication, it's just came out in the last year or two, but it does give us hope for patients that they don't have to go through such extreme procedures. So
let's go on then to discuss the other extreme, underactive thyroid. How does that present clinically?
Yeah, and of the two, this is much more common, underactive thyroid, hypothyroidism. The main cause of that is Hashimoto's. And again, another disease named after somebody who described it. So this is a Japanese doctor this time. And so it's a big fancy name that scares people. But again, just the description of the person who described an autoimmune destruction of the thyroid. So again, the immune system is involved here, destroying the thyroid. And when you destroy the thyroid, you don't make as much thyroid hormone. Now, a lot of times it's a very gradual, subtle process where you're just slowly making less and less thyroid hormone, but sometimes it's pretty extreme. And so some people will come in with no symptoms, but the blood test will be a little off. Some people come in with the full-blown extreme fatigue, weight gain, dry, puffy eyes, brittle everything, constipation, just feeling terrible, brain fog. The problem, of course, is there's a lot of reasons why people are gaining weight and feeling tired and cold. And so it's not always thyroid. And that is a bit of a discussion with patients who are convinced it's a thyroid, but the blood tests generally don't lie. So again, we go back to those two tests, the TSH, the T4. In the situation of hypothyroidism, underactive, the TSH starts to go up because the brain is sensing, I'm not seeing enough of this T4, what's going on? So it increases the signal to the thyroid. The thyroid can't do anything with that. It's being destroyed. It's doing the best it can. So the normal TSH range, I didn't mention this before, is about 0.5 to about 4. And everyone's a little different. Populations vary, but it's a good range. If you don't have any thyroid function, you can get TSH 100 or 200. And some people will come with a TSH of 8 or 9, just barely up. It's easy to know what to do with the people who have extreme hypothyroidism. Those who kind of fall into this subclinical or barely hypothyroid, we have to make an informed decision with the patient on, do we start you on treatment or not? The treatment, which is probably your next question, is if you can't make enough of the thyroid hormone, give thyroid hormone. There is no treatment for reducing the immune system situation to try to block the immune system from destroying it. There's no thyroid transplants. It's just, if you don't make it, you take it. And the generic name of that is levothyroxine. There's some other formulations of thyroid hormone, but the basic concept is you give the amount that you think the person's going to need based on how much they're still making themselves, body weight. You make your best guess, and every 6 weeks or so, we repeat blood work, make an adjustment until we get it right. And most people, we kind of get to the right dose, and it can be followed once or twice a year. Some people, it's challenging, and it seems like we're always making small adjustments.
You mentioned earlier that hyperthyroidism is associated with the name Graves' disease. I seem to recall way back when that hypothyroidism was associated with the term Gull's disease. Is that correct?
You may have learned something that I didn't. I don't remember that.
Yeah, well, I seem to recall that. And Dr. Gull was a member of the British Royal Court. And I think he published some of the original papers on hypothyroidism. But I may be wrong. We'll have to check. Now, why do people get not thyroid nodules like you showed earlier, but a goiter where the whole thyroid is swollen? When does that occur?
I mean, there are a lot of reasons for that. So again, if you get several large nodules, the whole thyroid grows. And those thyroid nodules could be those toxic ones, the ones that are overactive. They could just be cysts, fluid-filled. They could be solid. They could be cancer. But it's basically you're replacing the normal thyroid tissue with lumps and bumps in the thyroid. Another reason is iodine deficiency. So this is no longer a major issue because we iodinize our salt. And most of the world now has iodine in their salt. Why iodine in salt? It's just an easy place to put it. And before that, and if you go to certain places in the world, you'll see everyone, look at their neck, has a big thyroid, because iodine is the main building block for thyroid hormone. And if the thyroid can't get it because they're landlocked, they don't have imported food, they don't have seafood, it's not in the soil, their thyroid is going to grow and grow and grow because it's looking to make more thyroid hormone and it can't find the substrate. So it just grows. In those people, you give them iodine, shrinks. And in those people, they might be hypothyroid. They don't need thyroid replacement hormone, they need iodine, and it shrinks.
Paul, we're going to pause here for a public service announcement. More with my guest, Dr. Paul Sack, discussing thyroid disease. We'll be right back. We're back. My guest this evening is Dr. Paul Sack, an endocrinologist with the MedStar Health System in Baltimore. Paul, when we paused for the public service announcement, we were discussing over and underactive thyroid disease. Briefly tell our viewers, what does the term thyroid storm mean? It's a very dramatic sounding term.
Yeah, so thyroid storm is one of the endocrine emergencies. We don't have many of them, but this is one of them, where basically, for whatever reason, and usually it's Graves' disease or it could be thyroiditis, there are massive amounts of thyroid hormone in the system. And for some people, they don't feel great, but they can manage that. But then you add another stressor on top of that, a heart attack, an infection, a car accident, broken bone or something. And all of a sudden, the body just goes into shock. And the blood pressure will drop, the heart rate will go through the roof, organ collapses. I mean, it is really bad. And typically, again, it's when there's undiagnosed severe hyperthyroidism with an additional stressor. And in those situations, it's all hands on deck. It's ICU, supportive care, fluids. We give medicines that block the thyroid hormone from being made, that can block the the conversion of inactive thyroid hormone, that's the T4, to active thyroid hormone, that's T3. And we can also block the activity of the thyroid hormone on the cells with steroids and some other things like that. Typically, we can get the patient through it. And again, treating the underlying cause with the hyperthyroidism, but also treating the condition that triggered the whole thing. And again, this is one of the times when patients actually can have a bad outcome from thyroid disease.
Let's go on then to discuss the evaluation of nodules of the thyroid. Tell our viewers briefly, what are the different types of nodules you run into?
So it's interesting. I'm first going to talk about how frequent are thyroid nodules found. And the answer is vary. And if you look for it, you'll find them, which is a problem because, just because you have a thyroid nodule doesn't mean that anything needs to be done, but it's really difficult to figure that out. There was a study in South Korea where they added thyroid ultrasounds, which is one of the ways we look at the thyroid, to a kind of a routine screening test. And all of a sudden, their thyroid cancer rates and thyroid nodule rates went through the roof. And death from thyroid cancer stayed exactly the same, very, very low. So thyroid nodules are extremely common. They're more common in women compared to men, and they're more common in family members who have family members other than them that have thyroid nodules. So I go back to my little diagram here. So this is a little lump on the thyroid. This is about a centimeter. And we see these a lot. The nodules can come from a lot of different etiologies. As I mentioned before, you can have a cyst where it's just a fluid-filled area, or you can have some kind of change or mutation in certain thyroid cells, and one becomes 2 and 2 becomes 4, and eventually you have a nodule that, if the mutation is aggressive and serious enough, or if there are multiple mutations, that turns into cancer. So, as an endocrinologist, we see a lot of patients who come in with thyroid nodules. I would say about half of them are incidental findings. They go to the ER, they have a CAT scan of their chest because of chest pain. We see a nodule. Their neck hurts, they get an MRI. They have an ultrasound of their artery, the carotid artery that's right next to the thyroid. They see a nodule. So most of our patients were actually getting that never had any complaints. It was found incidentally. The other half, of course, it is something you could possibly see. They feel it, they see it in the mirror, someone else tells them about it, the doctor feels it. Dentists are good at finding them, OBGYNs are really good at finding them. So it kind of comes from everywhere. The initial evaluation of a thyroid nodule is very simple. We want to make sure that the thyroid nodule is not overactive. So we measure that thyroid test again, that TSH. If the TSH is super duper low, we kind of go down one route, and if it's normal or even high, we go down a different route. When there's hyper or overactive thyroid with a thyroid nodule, that is probably going to be a hot nodule. We can do a certain test that's called an iodine scan. It's a nuclear medicine. It sounds scary because it's nuclear, but very low doses of radiation. And we can tell that nodule, is it causing the overactivity, or is there something else causing the overactivity? An overactive nodule is never cancer. We still have to treat it. We have to figure out how to treat the hyperthyroidism. We don't need to worry about cancer. So that's the minority. The majority of thyroid nodules are associated with normal thyroid function. In those situations, the next question is, okay, what are the exact characteristics? So I can feel it maybe, but we need to do an ultrasound. And it's interesting, people think MRI, CAT scan, those are the sexy kind of tests, but no, the ultrasound actually gives us the best definition and characteristics. And I personally like to do my own. I have my own ultrasound machine. I'm looking at the characteristics of the nodules. Other people don't have that ability, so they'll send them off to a radiology. But you basically get a couple characteristics. How big is it? Does it look a little brighter, a little darker? Are the edges intact, or they look a little funny? How much blood flow is in there, and is there calcium deposits? And each of those kind of gives us a kind of a probability of like how worried should we be. But the ultrasound is not going to tell us the answer. If we really have a suspicion for cancer, it needs to be aspirated. And that's what we call a fine needle aspiration. These days, that's done with an ultrasound guidance. So the person's laying on the table, ultrasound probe, a very small needle, much smaller than what we use to draw blood, is inserted, get a little tiny sample, and a pathologist looks under the microscope and can tell us about the characteristics of the cells.
If a nodule is found to be cystic with just fluid inside, are you still worried about malignancy, or is it always benign?
Yeah, those are, I mean, 99.5%. You can't ever say always in medicine, right? So 99.5% chance. So those still can be annoying because these cysts can get big and they can get in the way. But typically we don't worry about malignancy. We can drain them, they can be surgically removed. So cysts are less concerning than something that's solid, and especially something that's growing. So a lot of times we're like, look, we're just going to watch this. We'll do an ultrasound in 6, 12 months. And a growing nodule can be a risk for malignancy, although lots of nodules that grow are still benign. The risk of malignancy, all comers, depending on the study, 5 to 10%. But there's certain nodules, when I look at it, I'll tell the patient, I think this is going to be cancer. We're going to biopsy just to make sure. Or I'll tell patients, we're going to biopsy because it's big, but man, this just looks so benign. I'm just going to tell you, I'm not too worried about it. So I try to let my patients know kind of how concerned or not concerned to be. But once we get that biopsy results back, it kind of puts this in two directions. If it's benign, we're going to watch. If it's risk, if it looks like a high risk for malignancy, they need surgery. And then this is a surgical disease. There's not a pill or chemotherapy or anything like that. This needs to come out.
Now, of course, adjacent to the thyroid gland are the parathyroid glands, which control calcium metabolism. So how do you do treatment with a thyroid surgery without losing your parathyroid glands?
You find a good surgeon. So yeah, I mean, there's a lot of things neighboring, and so we don't send people to surgery lightly. We really want to make sure that we're doing it so that their long-term outcomes are going to be better because they had surgery. And surgery, listen, there are bigger surgeries. There's heart surgery, there's abdominal surgeries. This is an overnight in the hospital kind of surgery, a small scar here at the base of the neck. And most of the time people do great. But the adjacent structures are important. The parathyroid glands are important. If you take out, there's 4 of them. If you take out all of them, you got to be in special medicines. Otherwise, your calcium is going to be low the rest of your life. The vocal cords are supplied by a nerve that goes right behind the thyroid. And if the surgeon nicks that, you can end up with a hoarse voice, temporarily or long term. But again, you find that we have good relationships with our surgeons, and so we kind of understand that. And the surgeon has a long discussion with the patient. These are the risks and benefits. I mentioned that we do surgery for cancer, and I think this is not quite the place to talk about which kind of surgery. You take out half, you take out whole, but that's a discussion. The other reason we do surgery is when the thyroid's getting in the way. We biopsied it, it's not cancer, but they're having trouble swallowing now. I mean, if you think about, again, where the thyroid lives, and here's my thyroid, you got a trachea, that's your breathing tube, and what's not shown here, right behind the thyroid, is the swallowing tube, the esophagus. And that poor little esophagus is floppy. You know this. And it can get kind of pushed between the hard rings of the trachea and a big nodule. So patients will tell you they're having trouble swallowing. They can't swallow pills. They have to chew their food a lot. They could have a hoarse voice because that nerve that I talked about before can be pushed on by those things. They could literally have positions in which they turn their head or they move their neck when they're sleeping where they're like, I can't really breathe right now. I mean, those are extremes, but again, the thyroid needs to come out at that point if it's really causing those symptoms of compression.
Well, I'm glad you brought that up because you mentioned all the specialists who refer to you. And I do want to acknowledge gastroenterology, since we do pick up occasional thyroid disease for a patient with swallowing difficulty with a negative ENT and GI evaluation.
Yep. It's the typical questions we ask: swallowing, talking, and breathing. So just to make sure, but again, it needs to be something that's pretty big. We're talking about 3 or 4 centimeter nodules before it really gets in the way. And by that time, I think the patient, they know it's there because that is not subtle.
You send someone to surgery for a so-called cold nodule. It's confirmed to be a malignancy. When it's removed, what is the next step for thyroid cancer treatment?
Sure, and this is an evolving field. We have overtreated thyroid cancer for a long time. And I know that sounds strange, but for a long time when I was training, it was get out the thyroid and give a lot of iodine, radioactive iodine. And now with smaller nodules that turn out to be cancer, especially if they're not very aggressive, we can get away with just half the thyroid. But if you have an aggressive large thyroid, or if there looks like there's suspicious nodules on both sides and the entire thyroid comes out, we make a decision, which is we know the surgeon, the best surgeons even, can't get every little last piece of that thyroid out. And maybe they left behind some abnormal thyroid tissue. So in those situations, we give a dose of radioactive iodine. And again, remember I told you iodine is the main building block for thyroid hormone. So if you give a patient radioactive iodine, it's going to go to those cells that want iodine, the thyroid cells. And it can kill off the rest of it, whatever the surgeon couldn't get out. Now, it also kills off whatever the surgeon couldn't get out that's normal thyroid tissue. But that's actually good, because over time, then we can have blood tests to measure a protein that is normally made by thyroid tissue called thyroglobulin, and that's kind of our tumor marker. So if you had the surgery, you get the radioactive iodine, and that thyroglobulin remains low, you're pretty sure the thyroid cancer hasn't come back. So typically,
we're going to need to stop here. We're out of time.
We'll have to come back to talk about that one.
Yeah. Well, thank you for a superb review of thyroid disease. If our viewers have any questions, how can they reach you?
Well, we're all very busy endocrinologists here, but at MedStar at Union Memorial, it's 410-554-4511. And in Montgomery County, there's a great couple of endocrinologists at MedStar Montgomery Hospital.
My thanks again. My thanks to my team at the studio for making this program possible, and thanks to you, the viewer, for joining us this evening. You can reach me at my website listed below on the screen if you have any suggestions for future programming. As for our next show, it's going to be a fascinating one. We'll be interviewing several guests on celiac disease, wheat allergy, one that has many, many manifestations, including thyroid disease. In any case, we look forward to seeing you next time on another edition of Housecall. Good evening.